for that care to be delivered. Obviously, we're there to help people recover from injury and self-care. And as I said, one of the other issues is about helping people manage their ongoing physical and mental health conditions. A lot of the strategy that is coming out nationally as well as being fed in locally is about supporting people to manage their own healthcare. We know we have a lot of challenging characters in our communities that don't tend to take that on board, but in essence we need to work with them and educate them and support them so they can actually manage their own healthcare better, and therefore maybe not use NHS resources, which really is not really what they need to be doing at the time. It's about helping themselves. And of course, the ultimate goal of those commissioning the health services about patient-centred and outcomes-focused. And for me personally, having worked in CCGs and provider services for over 20 years, one thing that I've always sort of been focused quite on is outcomes-based care, really. And I think sometimes we do deliver services that don't actually deliver the outcome that we're looking to deliver, or we've not really made it clear at the beginning about what is the outcome that is trying to be achieved. And certainly myself, working as a head of commissioning in the CCG, and my background is actually in nursing and mental health in general, is that we need to be delivering something that is measurable, that we can see has tangible effects and actually does deliver. But quite often we fund services or commission services that actually, if they didn't exist in the first place, would have made any difference for the members of the public, really. So apart from those 5 key issues we talked before, it is very much more about outcomes-based and patient-centred. And one of the things for clinical commission groups in this year, in terms of their assessment framework, it will be asking and looking at how CCGs are commissioning outcomes and delivering those outcomes of service. And whereas some CCGs may not have scored well in the last assessment framework around some areas, then this is where the focus really is on this year. And even those that did look that they did deliver outstanding CCG work, but actually the outcomes weren't as good as what they would have hoped to, and that will change the focus very much on moving that forward. I think it's also key to look again at what the NHS Constitution says, and this is basically a contract, arguably, between the government and the public, really. And there are, again, 6 key themes here that are embedded in the NHS Constitution, and arguably supports the direction of travel for clinical commissioning groups, really. And again, whatever we do, wherever we commission, whatever we provide, it needs to be able to hit these 6 areas, really. And again, if those areas aren't being met, or the work that's being delivered isn't being met, then I would question strongly again, are you actually commissioning the services that are required? So it is about working together with patients, and that goes back to the engagement issue I talked about a couple of minutes ago. It is about showing respect and dignity for the members of the public. It is about everybody counts, and that we shouldn't have any groups within our society that are marginalised or not focused on in terms of what the service they should be receiving. It is about commitment to quality of care. It is about compassionate care. And again, it is about improving lives. And again, we have a lot of assessment areas and assessment regimes, and just like the CQC, that are going into providers in particular and looking at those 6 areas, really. And I would guess anybody who works in the NHS says and is committed to delivering them areas, but if the work they're actually delivering doesn't deliver in them areas, then certainly you'd have to question actually the models of service they're providing, and why aren't they hitting in those key areas, really. And it has been argued in the past that providers very much deliver a service based around what they want to deliver and the individuals within that service, rather than actually being focused on the patients. And certainly from the CQC and those sort of assessment areas, this can bring this out, that the services being provided aren't actually supportive of what the patient needs are. In terms of the policy context, and I've just noticed in the last hour the NHS plan for the next 2 years has come out with the specifics around what CCGs are provided or should be providing over the next 2 years. But again, it doesn't, even this latest strategy document, operational plan, doesn't move away from this policy context. So it is about opening up public services to enable other providers potentially to come in and provide services. I guess you could argue that if your local NHS provider is providing everything they should do, is hitting all those NHS constitutional targets and those outcomes, then why would you bother needing to open up those services? But as we know, right across the country, there are a lot of services that aren't meeting those areas. And so one of the policy views is about enabling other providers who may be more specialised to be able to deliver those services. It is about personalisation and choice, and this very much goes back to user, the ability for the users to link in with those services and whether those services actually fit their personal need. So again, whatever we're going to provide, it needs to be personalised, and we need to give people choices around the care they are given. Sometimes we know people don't make the right choices themselves, but I guess that's one of the roles that we're here to do, to try and support and educate them. But again, a principle is around providing that choice. The changing funding environments and structures, we know the finances are a real challenge for us. And again, in the operation plan, it stresses again about providers coming in at balance and not overspending. And I would argue, we look at some of the, if you went through every budget line as a CCG, what you spend services on, are you actually putting money in the right places, and are providers actually spending it in those areas? I know it's a job easier said than done, but it certainly is a task that we need to take forward. We have new commissioners, patients particularly, are self-commissioners now. They will choose and pick the services they require, especially if we move into personal health budgets moving forward. Again, the clarity on this isn't very clear at the moment, but certainly is about having patients guiding where they want to go and using that money that they need to deliver. But obviously is about linking in more with other commissioning providers as well. So local authority, for example, are another big commissioner of health and social care services. So it is about how we link in together across those and other areas where there's potentially private investments, and other areas about how we can commission more effectively and not in isolation, and more around collaboration. And again, just referring back to the operational plan that's just come out, it talks about providing services and commissioning services on larger footprints in an integrated way. So it makes services hopefully seamless for the patients to enable to deliver those effective outcomes. Potentially there may be new investors within the policy context. And we know the investments from a national perspective is not growing in terms of what public need is, but also there may be other areas of investment. It is about outcomes focused. And again, I already made that point around, if it's not delivering a clear outcome that you have expressed the need for that service to provide, then should that service either stop doing what it's doing because it's not effective in its outcome, or should that money and investment be moved elsewhere? Integrated commissioning, as I've said, moving across the larger areas, linking in with other CCGs, larger footprints, local authority, and those sort of areas around. We may be looking at new mechanisms around payments. We do have payment by results, but will we look on a sort of broader network of payments? We'll be looking at bringing pots of money together to be able to commission services. And it still goes back to the localism issue about providing services, spending money on services and commissioning services that meet local need. I personally have worked across a number of health economies across the country, in the southeast, the Midlands and the north, and I would say any strategic plan or any areas of public need, 95% of them are all the same. Everyone has the same challenges. Everybody has the same local issues that need to be delivered and moved forward with. So I guess sometimes it's not about reinventing the wheel. It's about looking at what other people are doing and working on that as a benchmarked approach to providing services. In terms of evidence into action, and this probably goes back to this outcomes based, it is about what are we doing about early intervention and prevention. It is about a stronger partnership approach. It is about addressing all the wider determinants of health. And we've seen a big focus in the last few years on mental health. And I think it is now widely acknowledged that mental health has a huge impact on people's physical health as well. So how are we managing that approach, and how are we allowing people to be able to access especially mild to moderate mental health services that can put people of a more fitness in mind, which hopefully will make them fitness in body, and allow people to potentially go back to work and live a normal life, or a life that is one that they choose, that they want to do, and that will support their ability and hopefully maintain their physical health as well. So the wider determinants And this does go back to probably how maybe you're looking at in your local CCG about linking into education, into workforce, and other aspects of society which can support people's physical and mental health. As I said, mental and physical health are of equal importance to someone's well-being. It is about reducing health inequality, and again, that has been a big issue for many, many years, and life expectancy has grown, and we do have people living a lot longer. That is, as we know, bringing other issues with that in terms of older people with multiple conditions and how they're managing their lives, and we do know that hospitals are full of people who are of our older age group that have a lot of different areas of need, and that creates other pressures and strains on the services as well. So the positiveness is that people are living longer, but that brings other challenges with it as well. And it is about the importance of placing strength on building on the community's assets, really. And I think this, for me, does go about extending out to third sector, independent sector, and charitable organisations about how are the services that are already out there, how they can link in with the commissioning strategy of a CCG to enable the better use of resources and bringing that community together, and bringing it together in a way that will help the local public and work that through. So again, when an idea or thought comes across in the CCG around commissioning a service or reviewing a service, then how does it fit into those elements? How will it deliver those elements? And how do providers who provide the services that we are commissioning, how are they addressing those needs as well? And those are key evidence factors. So the challenge ahead, as I'm sure we're all aware, is laid out in the 5-year forward view, and that is the blueprint of where we're trying to move in the next few years. That has led to an importance on transformation of services. We look at a lot of services at the moment and they really aren't delivering the outcomes that we want to do. And yes, there is a big element around finance around that, but actually for me, it's about, are they innovating? Are they using value-based approaches to care? And are they delivering on outcomes-based care? Or are they delivering a service that effectively is not improving their local health, is still costing a lot of money, and ideally we are therefore going in the wrong direction. We have the National Business Plan, as I said, it's just been updated for the next 2 years, which came out today. And we're looking at new models of care, really, and multiple providers coming together. And they've been sort of looked at through the NHS Vanguards scheme that are all over the country that cover integration between hospital and community services, integrating with mental health services, and integrating in more work within primary care, and bringing all those two together. And I think my personal view from that is we know that the current models of service aren't delivering the outcomes that we need to be done. So the challenge has been thrown back out to those providers to say, how are you going to work differently? How are you going to provide services in a new way that will hit closer those outcomes and those constitutional targets and all of those things that we're trying to work through. What we're doing now is obviously not proving to be successful. I'm not sure how positive those vanguards are. Some of them have been running for a couple of years now. I'm not sure of seeing any of the evidence around the measurable and visual and tangible outcome improvement they've been done, but at least the pressure and the push is on doing something differently, and the challenges for those organisations supported by commissioners across health and social care to do that, really. If any of you have got any thoughts on your experiences around Vanguard or any of those issues around that, then certainly would welcome any of your comments through the chat box. So let's just talk quickly about the 5-year forward view. So again, what are the big boxes that need to be ticked when we're commissioning services moving forward? Then, as I said, there's acknowledgement that more needs to be done. There has to be a clear focus on prevention and public health. Patients need to gain greater control of their care, and they need to be empowered and engagement more. We need to reduce those gaps in well-being, quality care and efficiency, break down those barriers with a focus on stronger partnerships within health. One size doesn't fit all, and new models of care and a shift to moving services out of hospital. Again, I've worked as an operational director within Acute Trust, and that was only 3 or 4 years ago, and did question as to why are we delivering some of those services in these big buildings when actually they should be delivered out in community and primary care, but we also accept and acknowledge that there's huge pressures now on primary care. But if we can shift activity, which therefore money goes with that, back into that community and care closer to home, then that may enable and facilitate those services to be delivered there. We know that the biggest spend that we have goes on hospital care and acute settings, and acute for me is the key thing. If it's not acute services being provided, then why are they provided there? But we also know that there is a resistance from providers as well, the acute hospitals, about being able to reduce and downsize. But we have seen examples where we've centralised specialised services, and stroke in London was one of them, which initially had a lot of objection to, but actually that the results have proven to be very successful, that where services are specialised, it does provide better safety, better quality outcomes, and we don't necessarily need all singing, all dancing services in every single hospital. You ask any chief executive or board, one of their challenges potentially around increasing income rather than reducing income, but I think they need to get away from that philosophy and that idea, and I think that we will end up reducing big acute sites in lower numbers and making them more specialised, and pushing those other services and the income that goes with that back out to the community. And that may be one of the only ways we will be able to invest more in primary care and community services. So again, when commissioning services and looking at redesign or developing a service forward, that question has to be asked: where is the best place for people to do that? I know in some areas and some specialities we're not overrun with providers, but certainly in areas I've worked with and observed across the country, that support through CCGs has been with other providers to develop those services. So sometimes those providers aren't there, but how do we work with them to develop that and move that forward? And of course the 5-year view, and again reiterated again in the operational plan, is integration between all those services as well. And we do see duplication of services. We do see services that don't talk to each other very well, that don't pass the patient on in an efficient and productive manner. So how can these services be brought together as one entity potentially, to be able to deliver those services that we need to do? And of course we need to try and deliver a sustained and improved approach to the NHS in general. And again, we know there's a lot of challenges around that, but I would still argue that there is probably more we can do, and it does start with how we work with our providers and how we commission things differently. So what will the future look like in theory if we deliver this transformation of care? You'll see the diagram there with the two pyramids, and on the left hand side we have what things look like now. We have a lot of spend and a lot of services delivered in hospital and intermediate care, and not so much in primary care and prevention and self-care. But through transformation and through self-care, self-management, and a greater shift of activity and that funding that goes with that, then transformation would look like the pyramid on the right-hand side, which shows a spend on acute hospitals being less than what it is now and focused on acute services, supported by some intermediate services and specialised services, but the huge majority of services being provided in primary and community care, with a great focus on the public, on that approach to prevention, self-care and shared decision making. And again, whatever services, whatever strategy, whatever approach the commissioning CCG will look at, then that needs to be the direction of travel, and it needs to fit in with that transformational progress. Jackie's raised her hand, is going to ask a question. I'd be interested to know also, for hands up, that do people support the direction of travel for transformation? Are they keen for some or something? Are they keen to participate anyway? So do people support this form of direction? People want to put their hands up? So we'll just get a view on that. Okay, seems like a lot of people are agreeing with that, which is really positive. If anybody has got a question which they're not too sure about, then by all means, or they do have a query on that, by all means, please let me have your question. So Jackie's put a comment about, I get that the preferred focus on prevention in the future, but do we get from here to there? We need to invest in prevention. And again, Catherine has also said, where is the funding for public health and prevention? And that we need to look at that investment starting now. In my last role as in the NHS, because I work on it as an interim consultancy and have done over the last 4 years, one of the roles I've been looking at is contracting and procurement. So I think it's very clear from the government that there is no more money. So where will that investment come through for to look at prevention and those sort of areas? So really the approach needs to be taken is, what money can we take out of the system now, which arguably is not effective, not outcomes focused, and is not actually delivering something different or something new. Then we need to look at those areas really. And we do have, and I'm sure you have it in your local CCG, sort of an ever in growing priorities of low clinical value policy, in which we've looked at services that we would argue that may not be providing that real sort of improvement in public health or general people's well-being. And I do think we just really need to go through the whole budget lines again and look at where that spend is and how do we transfer that forward really. But I accept that, you know, in days gone by, we used to have programs and CCGs or PCTs as it was then to invest to save. Well, actually the focus now is in save to invest. So I also, living in the real world as well, accept that, you know, the ability to just shift money overnight is not an easy task to do, but we have to start somewhere. We have to start an approach to look at that really, and we have to work with our providers around their approach and how they provide services and how they fund services. But as I can see from the questions that have come through the chat, and people will be able to see that this challenge is not an easy challenge to achieve. In terms of Commission for Outcomes, again, this is often a challenging area in terms of what outcomes we want to achieve really. And very much the NHS constitutional standards are around timeliness targets. So 4 hours in A&E, 18 weeks of surgery, 62-day for cancer intervention, because they are quite easily measurable. But I would still go back to when we are looking at services and how we specify services, then we certainly need to look at sort of public participation in those services and the quality aspects of those services. So there's some already clear established outcomes frameworks in public health, NHS and adult social care, and on the slide you can see now are some examples of that and how they are being focused on those areas. But again, I don't think we need to overcomplicate some of these things really. You know, when you look at what is the definition of quality, it is about general safety. So are we doing harm to patients rather than good? So how can we demonstrate that through potential clinical audit or patient feedback? It is about patient experience as well. So do we need to talk to our public more and consult them more around what they feel they want? Because I'm sure that they still want to engage in services that are things that they want to link in with and what is good for them. And then around just basic other outcomes of improvement, and does it improve someone's physical health? Does it maintain someone's physical health rather than support deterioration? And does it enable people to improve their health and well-being, which may be about less use of services, more self-care of services or illness and disease that they may have? And do they have an ability to function better within society, within their role? But of course, you know, some of the comments being made now around prevention, around choice, about diet, smoking, alcohol needs to be done, and the budgets are disappearing around that. Again, completely accept that. But what you'll see later on in this presentation are some examples of where actually there's a small amount of the public that are actually spending the most on those resources. So what are we doing, arguably, about tackling those individuals and how they are interacting and engaging with services? Because the vast majority of the public generally do look after themselves and do manage their health in a more effective way. So how can we build and develop on that? In terms of sustainability and transformational plans, again, we have 9 must-dos for this year. So again, whatever we're doing, wherever we're going to commission as a clinical commission group, whatever things we're going to change, alter, redesign, or innovate, it needs to be able to support those sustainability and transformational must-dos for the system. And again, you'll all be familiar with those around those different services as well. Just seeing a couple of people typing some questions, so I'll pick them up as they come through. And again, please respond to your colleagues as well in the chat box around any statements or questions that people may ask. In terms of local strategy, well, Lambeth will have a strategy, and there's a slide of the front page of that strategy. But again, as I referred to earlier, strategies for most CCGs, again, are very, very similar, have the same challenges and the same direction of travel that they want to go to, and the same sort of approach or potential approaches that they are looking at. Alice has put a comment about, similar to Sarah and Justin, that really struggle with the social and the financial determinants of health, and it's a very tricky one to address. And I think one of the themes I want to say through this sort of web session is no one is saying that challenging these determinants and these issues is easy, and no one's saying that we're going to change all these things overnight. But whatever we do, whatever we're looking forward to deliver an approach, we must make sure that whatever we're thinking about, it must try and approach and link into those key issues around health and social care, and that providers don't just do things to people, that they support people, educate people, and try and support them in an ability to manage their own health and manage their own condition, and be able to hopefully improve their health and well-being. In terms of commissioning across the economy, as colleagues will know, Lambeth commission and co-commission across health, local authority, mental health, and with independent, voluntary and social enterprise. And again, the commissioning approach in that integrated way and across the whole economy, which may also cut across other CCGs and wider footprints, again is around these 6 key areas, which again all relate back to the NHS constitutional standards, the NHS constitution itself, the role of the NHS, and all of those areas. So what we're trying to do now has not changed in focus than what we're trying to do 5, 10, 15, 20 years ago. We are still trying to do the same things. I think the push and yes, the pressure at times from the national perspective and actually from what the public want is how are we going to actually make the inroads into them? How are we going to demonstrate that we can deliver those, and how do our commissioning and the business cases and the approaches we take, how do they stand up against those priorities? So what is the solution? Well, ideally to commission world-class services. And we'll touch on now really about the commissioning cycle, that I think we all want to engage in the commissioning process, but I would argue, and certainly from my experience, what I've seen is that sometimes we don't complete the full commissioning cycle. We do part of the cycle. We don't engage around that cycle. We don't use strong clinical input around that cycle. We don't see the cycle all the way through. And we don't actually follow the process in full. And of course, if we're going to put anything together, if you don't read all the plans and you don't follow the full process, then sometimes what you'll end up is something that just falls apart and doesn't actually deliver the true idea and the true focus and true vision of what you were trying to do. And are we used to commissioning? Well, NHS arguably may not have been the greatest commissioner in the past, and there's some areas where there is excellent commissioning and some where there isn't, but we do actually commission in our everyday lives about anything that we do and anything that we do purchase. We do look at the bigger picture and different aspects to help us make our decisions, and when we do make decisions that potentially aren't the best ones, then often what we end up with is not something that we were ideally trying to deliver in the first place, really. got a couple of questions or statements there around, does anybody know of any countries where they have managed to address those financial determinants? Catherine's just put up a link to an article in the Guardian. And are there any workable examples? Again, further on in the session today, we will look at some of the practical examples, and I would argue again that the NHS is very good in parts, in places, at coming up with new ideas and approaches. But I would then ask, why isn't that not delivered on bigger scales across the whole country? So there are lots of great examples where we have shown those improvements, but arguably we've not always taken on board those examples and delivered that forward. Just there's a brief sort of page on the short history of commissioning, and again it's trying to be brought through in terms of primary care, in GP fund holding, practice-based commissioning. So we've had a good few attempts, arguably, for the last 20 to 30 years of commissioning in different forms. But again, I'll go back to my point, is whatever form or whatever organisation we were called then, or functionality we were then, arguably we've not probably commissioned in the most effective way. So again, this is the commissioning cycle, and again, you'll all be very familiar with this, hopefully. And just to sort of go through it quickly, you know, the first one in blue about assessing need is about assessing what is it we're trying to do. Where are we trying to go? What are we trying to deliver? Are we clear about what is the demand in the issue? And I would argue in the past we've looked at sort of new initiatives like walk-in centres and other similar type facilities in the community, and the argument back has been, well, actually all you've done is increased activity. You've actually given the public more reliance on going to the NHS to seek out support and treatment, rather than supporting them more closer to home around how they can support themselves. But being very clear about what you're trying to do and where you're trying to go is a fundamental issue to start with. And again, I don't think it's too complicated, because I think we just go back to those key things in the NHS constitution, the key role of the NHS. This are the things we're trying to do, especially those who are our clinical colleagues that are front line. You know, you will see every day in your work the issues that you're faced with and the public are challenged with. So once you're sort of clear about where you want to go, and that may be using some evidence and best-based practice, is about reviewing, does your current provision actually deliver those? Is the service specification, for example, clear for the providers as to what they're supposed to be delivering, and are they actually producing the outcomes and the outputs that you're expecting for them to deliver? And once you've looked at those elements and you have a clear view as to whether the local functionality is working or not, then decide on and agree the priorities as to how that needs to be taken forward. And the fourth box in the cycle about specifying and agreeing quality outcomes, for me, and I've said it time and again, is absolutely the key requirement. Normally when, so especially working as a provider and working as a commissioner, when there's a challenge around a service being provided and the output and the delivery it's actually providing, when that conversation has taken place, then quite often it falls back to the service specification and the outcomes that are being measured. And if the service specification is woolly, if the outcomes aren't very clear, if they're not measurable, if they're not reportable, if there's no ability there for them to actually demonstrate clearly about the benefit that service is providing, then you'll get what you're given. You know, and I sort of use the analogy of buying a car. When you go to a garage, you have to break down a specification of what it is, what you want, what it looks like, what it'll deliver, what extras added, etc., etc. And then you're being very specific about what you want to be able to provide and what you want to be able to deliver for that garage to deliver on. And when we specify and agree the sort of the outputs in healthcare commissioning, it should be absolutely no different. At the end of the day, you'll get what you specify and you'll get what you ask for. And when challenging conversations come up with providers, you know, as a provider, they'll fall back and go, well, that's what you asked for. That's what's in the specification. Am I delivering that or not? And you might be saying, well, you are, but it's not actually delivering the outcomes you want to deliver. Well, maybe you're asking us to deliver the wrong things, but there has to be a huge reliance still on um, on the provider as well, because they tell us they are the experts in their field, they tell us they are the experts in those things. So what are they contributing to that service deliver? Then once you've specified and agreed the outcomes, then design and contract and procure for those services that you're getting and wanting to deliver. And then the boxes that are highlighted in green quite often are an area that we don't do very well. We don't then manage the providers properly. We don't hold them to account. We don't get the information that they're supposed to be providing. We don't manage and performance manage the outputs and the outcomes around that. We don't involve our clinical colleagues as much as we should do in performance managing those providers and challenging providers around the services we deliver, and then quite often just continue to pay for those services that are not delivering what they should do. And consequently, we don't always manage the quality, performance and outcomes. In the national standard contract that we use, there are a lot of key areas in that contract that actually, from a contracting perspective, we don't actually contract very well, and we don't enforce that contract, and we don't work with our providers and, as I said, challenge and proactively manage our providers on that. We just get what we're given. They deliver what they want to deliver. It doesn't give us what we want. And then after 12, 18 months, we're there scratching our heads going, well, I'm not sure what we're getting here, and I'm not sure whether this is actually proving effective or not. Just want to say thanks for the comments that are coming through. I'm sure everyone can read them as we go through, and that's giving us a good debate at the moment. So in terms of what are our 7 key approaches? What are the things that we need? What is the approach? What is the philosophy? What is the issues that should drive us forward in what we commission based on those sort of core requirements and those core issues that we're trying to deliver from an NHS perspective? Is we need to be bold and brave with strong clinical leadership. We need to challenge. We need to stop if it's not working. We need to change it if it's not working. Potentially, if we've contracted something and it's not functioning, we need to stop the contract. We may then look for other providers. We may want to work with our local providers, but to not be bold and brave and just potentially let the services, those providers that are just delivering what they're delivering, we need to face up to that challenge, and we need to challenge them on that. We need strong and effective participation and co-production. We need to work with our providers. We need to be there. We need to meet with them. We need to observe. We need to work closely with them, and quite often that can work in a very effective way. But as I said, in other areas, we have to just say to them, we're not continuing with this. We're going to stop this, and we're going to look at a different approach. We need to be clear about our vision of our local service provision. That will go back to our local and national strategies. We need to be clear exactly what we're asking for, what we're trying to buy, and what we see as success. Because quite often we don't measure success, or we don't know what success is, and we can't communicate back to our public that we have been successful in those areas. And by being clear about what successful is, we can then articulate that to our providers and say that what you're providing is success or it's not. We need to look and design our services of the future, but not just about playing around the edges anymore. We need to almost, in some areas, go back to the drawing board and redesign and therefore recommission services. Where I was working more recently in the West Midlands, 3 out of the 4 CCGs that work in an area were all regarded as outstanding CCGs. So out of the 10 CCGs out of the 200 in the country that are outstanding, 3 of them were actually on the same patch. One of the areas they were looking at was about mental health, and from the NHS England perspective, they asked them to provide us with a new blueprint of how mental health services could be delivered differently, not just as a provider, but how they link in with secondary care, primary care, education, housing, and local authority. They produced a plan. They went down to London, and I think they may even sat in front of Simon Stevens, or certainly members of his close team, and presented their plan and their future. And actually the response was quite disappointing from NHS England. I mean, what their response was, you are 3 out of our 10 best CCGs, and actually what you've designed and put together as a blueprint is something which is just playing with the edges again. It's not transformational. It's not thinking outside the box. It's just arguably more of the same with some slight alterations. So from the centre, they are looking for something radical, something new, something different. I guess the Vanguards are trying to help us with this, although I would question the success they have done, but they are looking for these absolute key changes and transformation of services. Just reading through some of the comments we've got here. Managing contracts is time consuming and thus expensive, and the NHS seems very divided about spend on. Well, I would still argue strongly that, the relationship you have in your day-to-day life with providers you provide with is through some sort of form of contract. It is something that it is a framework. It sets the boundaries of where we need to do through. But I think maybe the examples that you've come across as working in a contracting basis that just goes round in circles, doesn't focus on the key areas, and actually spends a lot of waffle and a lot of time and doesn't get down to the nitty gritty. And certainly in contracting discussions I've led on through negotiations and led on a day-to-day basis, we try to cut out the rubbish, cut out the sort of the discussions that go nowhere, and actually focused on exactly what the issues are and brought them back and brought them more accountable around that. And we have to do more than that. I accept if some contracts aren't working very moment, we have to go back to the drawing board on them. But certainly, we have to move to a position where we are more effective around that. And Natalie there talks about Lambeth, about transforming mental health services in partnership and delivering services including different partners, which is absolutely fantastic and definitely is the way forward. And then, as I said, in terms of the point 5, we need to make sure we secure those things. We need to have the commissioning mechanisms to drive the improvements. And again, that will link back to the contract as well as other areas, and then use active management of today's services to plan the future. We have to go back to these key principles. We have to deliver and work using these key principles, and they are the key principles of commissioning and the commissioning cycle. So again, we just need to potentially up our game in some areas and bring those back to the forefront with strong public engagement, strong clinical engagement as well. Okay, we'll have a short break. I'm conscious that sort of people looking at the screens now for the last half an hour or so. So it's 21 minutes past 2 now. So if we come back at 2:30, and then we'll go through the next phase of the webcast today. In the meanwhile, if people have got any questions that they want to raise with me to start off the next session, then please put them in the chat box. But we'll come back at 2:30. Hi everyone. So hopefully you had a little break there before we move on. I've just put a poll up there about what are your thoughts or what thoughts you have about delivering the commissioning strategy. We've had a few results back, and in short, people do believe that the strategy is the way forward. I accept that having the time to do the work, because as we said, the work is massive. There's a lot to do. But I think we need to pick it off in chunks really, rather than try and change the world overnight. People are keen to get involved in the delivery. One person said, I'm not too sure what we need to do. So hopefully the next part of the session will give some sort of idea about where we need to go and what are the things we need to focus on. So I'll just close that down now. Okay. Just out of interest, as we go through the session, if people if people do feel that this is familiar, it is sort of the things that they are doing, and they've got examples of other stuff that they have done, then please share that with us, really. Justin just said, can you point out examples that you know where there are good quality outcomes? Well, hopefully in the next sort of session or throughout the rest of the webcast, I will revert back to some areas where there have been some good outcomes and some sort of good areas of delivery. Okay, this is a phrase that I use quite a lot, and I like it actually because I think it sums up what we get for the input we put in. Every service is perfectly designed to get the results it achieves. I know when I contract manage with providers, especially around services that are performing poorly, and they look at me and they shrug their shoulders and they go, you know, we're trying everything we need to do, we're trying everything. I always come back to this. Well, whatever you're delivering, whatever model of service, approach, the way you are sort of providing that service, it's designed in a way that produces the outputs that you get. So obviously the way you're providing a service or the way you're delivering a service, it's not delivering the output and it's getting the results which unfortunately at times are poor. So you need to go back and look at exactly how you're delivering the service, why you're delivering it, what is it you're trying to achieve, and how you're trying to get something out of that which is positive. But the design, the way you run your clinic, department, area, pathway, you're getting the results that pathway or service is delivering. So arguably, change the pathway, change the service. Okay, we'll move on to the next one after that. So just going a little bit more into the commissioning cycle really, and just more specifically about things to focus on and to look at in terms of how do we get from the position of scratching our heads thinking this is going nowhere, this doesn't seem to be delivering, to actually getting to a point where we are getting something that we are aimed for, it fits our ambition, our philosophy and our strategic direction. So when we're looking at needs assessments, you know, sometimes it is about, I'm a great fan of going back to the basics, going back to the beginning again. What is the local data that we have telling us? What is it saying that our services are providing? And what is the information shared that we can see? What is the outputs it's telling us really? So there are a number of sources of information that are available at hand now, either within the CCG, potentially in provider outputs and their clinical dashboards and their reports, local authority and joint strategic needs assessments through public health. All of these organisations together are producing information, data, outputs, which is telling us and creating the picture that we're looking at really. So as you can see on that slide, is around prescribing, community health profiles, housing data, education, local authorities, practice-based information. All of these things are telling us the picture and are painting the picture of what our area is. Then we go back to what was in the NHS Constitution and all of those strategic documents. Is what that data is providing hitting those targets that we're trying to achieve? That should give you a picture as to where you're going and how your local services are performing. So if what you're getting or what the services you're commissioning is not hitting those, haven't looked at that data information, it is then about going back and reviewing that service and taking the time to look through that service in a joined up way, in a joined up manner with our colleagues who are providers and other commissioners and other groups really. So it may be about understanding how the operational delivery of that service is. Are there any workforce issues? And we know there are a lot. What are the clinical factors of the service? What are the effectiveness? Is there any information to tell us what the effectiveness is? Is it showing us, is it giving us any sort of intelligence that is telling us whether it's good for patients or not? Can we benchmark our services against other indicators and other information? And I would imagine, because most CCGs are, certainly most trusts are members of the NHS Benchmarking Network as an example, that will tell you how you stand up to other providers, especially in other local areas. And we'll talk about right care, right place as well. You've got some very detailed information around that. Again, just day-to-day reviewing indicators and performance against those national constitutional targets and any other indicators that are set out in the current service specifications. What do the public say? What are their views? What are they telling you about those services? How does it feel for them? Is it something that they feel they're benefiting from or not? Are they easily accessible or not? Are they actually improving their health well-being or not? And then also from looking around at other best practice and other evidence around how do your local services stack up against those sort of things. So it's creating the picture as to what is good, bad or indifferent about those services and getting that evidence base, because that evidence base will be important if you're going to push through a transformational change, because people, especially those delivering services, will question, what do you mean my service isn't doing very well? What do you mean it's not producing the outputs that you're looking for? What do you mean it's not producing those outcomes? That evidence will drive forward that potential change and movement. So when you've looked at all that information and all that evidence that is supporting what your local population is getting, it's then about prioritising. We know in areas there is so much to do and there are so many areas to focus on. And I've worked with commissioning colleagues and CCGs where that they have a set of priorities as a team, whether it's around unplanned care or planned care. And I met, as an example, I met a commissioner in my most recent place of work who was spending a lot of time on translation services. And I did ask them, why are you spending so much time on translation services? Not that it's not an important area to look at, but how did that become a top priority for you when you're looking at out of hospital services? Well, they said, we seem to spend a lot of money on it. We're not sure if the patient feedback is good, and it does seem to be escalating. So when we talked about, well, how much are you spending on that service? And they said about £250,000 a year. We think we could probably save £50,000 by redesigning it and restructuring it better. And I said, well, yeah. So what are you doing about your diabetes pathway? What are you doing about your long-term conditions pathways? What are you doing around other pathways to do with respiratory or cardiology, which you're spending millions of pounds on, which you're not convinced is delivering a good health outcome for your population? So I'm not saying translation services aren't important, but why are you spending a lot of your time on that when arguably it's small fry? It's a small issue, something that, yes, needs to be looked at some point, but isn't the fact that you've got a rise in your diabetes profiles of your patients, or there's a lot of usage of children in A&E because of services that potentially are lacking in the community or not being delivered in the community. These should be your priorities, because these are the ones that will have your biggest impact. So again, coming back to sort of look at what are we focusing on? What are the big players, the big hitters in those priorities? What are the ones that will have the greatest output and the greatest deliverability? And what are those areas that will actually potentially change the course of the outcomes that your public is receiving at the moment? So again, this focusing on those key priorities based on the information you've seen has to shape and focus the work profile that you're moving forward in the next year or two. And then when you're sort of looking at an area or focusing on an area and you've already had the information to tell you that it's not as good as it should be, then going back and saying, well, what do I want? What will success look like? What will achievement and improvement look like? And how then can I specify and agree those quality outcomes? And sometimes it's about how those quality outcomes are then measurable. Can they be reported? Is the systems in place? Will you get that information? Are you asking of a provider something that is not achievable in the short term around that? So again, you have to try and work on the basis of those quality outcomes. And again, if I go back to those three issues around good patient experience, services that are safe, and services that are moving in the direction, the health and well-being of the member of the public, that will show tangible improvement and tangible benefit. So how are you specifying your service to deliver on those sorts of things that will give you those sort of outputs? And again, you could probably just Google a diabetes pathway, for example, or diabetes service specification, and you'll come up with dozens and dozens that are being used across the country. And so why reinvent the wheel? Why not look at them, pick out the best bits, and sit down with providers or your local provider and to say, I want to move this service in a different direction. I want it to focus on different things. I want it to be able to deliver on these measurable and tangible outputs that will give me the success factors that I am looking at, really. And I need to really nail down and be really specific around those service specifications. And there is a template within the contract that people can use. People often focus on the specification as the evidence base. You should be focusing on the outputs, the indicators, the direction of travel, how you're going to manage, performance manage, and how you're going to show and develop, demonstrate and give clarity to your own CCG board and the members of the public that this is the direction of travel we're trying to move on. Just moving on to the next slide. And yeah, sorry, I put NHS Greenwich there as a mistake. I meant NHS Lambeth, but basically every NHS CCG. So again, for me, outcomes are the results people care about most when seeking treatment, including functional improvement and the ability to live normal and productive lives. So then about designing those services and those pathways. So you've understood the need, you've looked at what you want to go, you've looked at what are the measurables and the ability to be able to deliver on those things, and what does the specification look like, and what will it look like in the future to deliver. And then to the contract, and we talked about the contract being quite a time-consuming process, and it can be if people take it down a time-consuming process. But if the specification within the contract and the detail in the contract is very clearly set out and clearly measurable with what then should produce for example, a clinical dashboard to show the indicators as to what will tell you whether it's going in the right direction or not. And actually the contract can be quite a big document, but it's actually the specification informs the other sections of the contract, really. You just pick up the information around quality outcomes, around service development, around activity and data collection, and that then focuses into the contract itself, really. One example I've worked on in the past was around maternity services and the delivery of maternity services. We have an NHS maternity review that came out this year, but what that review tells us is not actually anything new. It's just built on other reviews that have happened over the last 10 or 15 years. And as an example, what we did with our local provider, this was when I was working in the Northwest, is that the direction of travel around more continuity midwifery care, around more community-based midwifery care, around the focus on greater outcomes around parenting skills, the women's experiences of services, their feeling that they were getting the services they need and the interaction that they needed, as well as some of these core national indicators we have around black breastfeeding figures and caesarean section rates and reducing smoking. But we tried to work with our local provider, which is our local trust, really, about developing that maternity service and trying to re-specify it so it's more patient, woman focused, it's more community delivered, and 2/3 of women have a normal pregnancy and have very little need for anything else apart from midwifery input, and talking to the hospital about focusing purely on the other third that have acute conditions as well and may need obstetric medical input, but how do they shift 2/3 of their service into the community? And the reality was they just didn't deliver anything that was new. They just continued what they were doing. It was all very hospital based, very hospital focused. It didn't deliver continuity. It didn't improve the well-being and experience of women in the service. It did have a high caesarean section rate, and it didn't really promote normality and those sort of elements. So actually what we did was we re-specified the service. They said they couldn't deliver it, and actually a group of midwives who worked in the NHS who wanted to form their own community-based maternity service came out and then said that they'd like to deliver a service. So we then worked with them and designing the service, the pathways. We were very clear about what it should do. We were very clear about the model of service. We were clear about the activity they need to produce, how they were going to produce it, how it's going to be reportable, how the service is going to set up so it collects that data at the beginning, and how we were going to fund it and pay for it. And what we then produced was an alternative choice model of service, which that was in 2010, and 6 years later it's now being provided across a number of CCGs as a choice option. But that was about working with a provider and creating something completely different and creating a specification and outcome measures that were completely different, but they were all focused back on that continuity, experience, safety, and good clinical outcomes and safe clinical outcomes. So, it was about the ability of redoing that, and that process again was put then into a contract and put in that sort of, and we addressed all of those issues that are in the screen you can see. Just thought I'd really sort of touch on sort of the new models of care as well, which is a discussion at the moment. And I talked earlier about the ability to work across providers, work across commissioning organisations, and here are sort of 5 examples of new models of care that are being trialled and pushed out across different parts of the country really. So it is about acute care collaboration, for example, where local hospitals are coming together to provide specialist services on specialist sites and hot and cold sites, which is something that they're doing in the Greater Manchester area at the moment. Multi-speciality community providers, that's about primary care coming together with community and mental health and community hospitals coming together as one organisation and one pathway approach of care. There's also some models that are being looked at around the integration of primary and acute systems. So that's joining up everything within that local health economy. There's obviously work going on around urgent and emergency care, and that's quite prevalent with services like the ambulance service and 111 around all parts of the country at the moment. And then there's other models of care looking at enhanced health in care homes as well. A lot of our elder generation are in care homes. Often the provision in there is quite poor, the support is quite poor, and as soon as somebody has any sort of deterioration in their condition, even if it's minor, usually the care home's response is to pick up the phone, ring 999, and the patient ends up in hospital and then ends up there for a week or two before they're then discharged back. But I think the idea really is when understanding the local need, specifying what you need, but specifying it in a different way, in a different model, with different providers working together to be able to provide that care, to be able to deliver those outcomes and that specification that you've delivered. Some other aspects of the commissioning cycle is that even if you do come up with a new specification or a revised service specification, how do you get someone to deliver that? I guess, the ideal way is you work with your local provider to do that. But if the engagement isn't very good, if there's not a strong willingness to change, then one of your options may be to go out and procure those services. And I'm not sure how much of you have been involved in the procurement of services, but there are more than one way to try and get those services provided for your local health need, really. And also we are bound by regulations within this country and within Europe about how we procure services as well, really, and sort of there are financial thresholds around that, really. So there is, if you're not getting the provision that you need at the moment, or you wanting to provide something in a different way, then procurement is an option. but any procurement is only as good as the specification and the ability to work with providers in your local area or bring providers into your local area to provide those services. And again, where procurements haven't gone well in the past, it's been because the way it's been specified, the outcomes, and that sort of process hasn't been strong to begin with. But if it is strong, it is very clear, it is very sort of, it has the ability to be specific about what is to be delivered, then a procurement approach may be taken. So it may be with across large providers, it may be on any qualified provider approach, and there may be some sort of small mini competitions with local frameworks and other competitive tender approaches. There are some key themes and principles around procurement, but any of the procurement teams you deal with, whether it's with internal or whether through your CSU, will be aware of all of those principles and they'll guide you on that sort of way. So when do you procure? When an existing contract is coming to an end, when you require a new service, when you've remodeled a new service, or significant changes to an existing contract, and you may need to test the market for innovation around that. Again, a lot of the criticism about procurement is that they can be time consuming, and yes, it can be quite time consuming. It can be another bureaucratic process to put in, but unfortunately we are sort of at the behest of the procurement guidance and guidelines. Or actually, if you're working with a provider for a number of years and it's just not happening, it's just not going anywhere, and there's a clear indication that it's not achieving the outcomes, then I think procurement or a way of procuring the service differently has to be a strong factor for discussion within a clinical commissioning group. As I touched on earlier about the contracting, and then when you do procure or recontract with a provider, then it's important that the contract is completed in a robust manner, has all the sections completed fully, which will enable the contracting and the process to performance manage the contract. So, and where arguably the contract isn't detailed clearly, doesn't have all the information in, or is woolly in sections, that's where contracting can just like drag on and on and on, and you don't actually get what you want, and there isn't really a clear way out about what you want to achieve really. So contracting is a part of the process, it is part of the commissioning cycle, it needs to be done and managed effectively, otherwise all the other good work that has been done further earlier on in the commissioning cycle will have gone to waste. And of course, as I've said, the contracting process ensures that there's formal agreements and that there are specific areas of the contract that will be managed accordingly to ensure that you are achieving and getting the success that you're looking for, as well as a value for money approach and a quality effectiveness. And again, one of the other issues is around CCGs being able to manage the demand and ensure the appropriate access to care. So CCGs need to have in place a range of responsible providers that can commission services from. So it might be about bringing in new providers. They'll also need to understand and predict the current and future demand. So prediction of services and how services will change and how activity will shift needs to be built into that commissioning cycle, and employing the knowledge of future priorities and aspirations of the CCG, as well as local and national directives. And again, as I touched on earlier, is about managing the quality, performance and outcome. If this part of the commissioning cycle is not undertaken in a robust and focused manner, then there's a likelihood that the services you've just commissioned will not deliver on the outcomes that you've wanted to. And again, there's often discussion about what is value, how will value be delivered, and again it links into a number of different things really. It links into what is your user's definition of value, what is the outcomes and the measures you're looking at, how does that link into the money that's being spent on it, is it proving positive? And again, a lot of priorities of low clinical value will be based on this sort of calculation about, is this spend creating the output and value that you're looking for, or can you create better value and output with the money that you've got available? But again, it comes back to those key definitions around outcomes again, and being clear about what is success and what is the value that you are looking for. So Alice is going to have to leave us. So thanks, Alice, for the input and the questions that you've put through. And again, a bit complicated, but in terms of contracting for values, this is an example, or these two are examples of some out-based commissioning that have been done in the Croydon area. And in a previous life I worked as the head of transformation in Croydon CCG, and was sort of contributed to trying to deliver this larger contract that is very much based on outcomes, and that is focused on the ability to work with all the providers coming together in some very clear outcome measures. That specific outcome measures were being developed around that, and so we can actually demonstrate whether the value and the contracting that we're spending will achieve the outputs that we're trying to look at doing. Okay, we'll have another short break for 10 minutes. So if we come back at 3:10, and then we'll go through the last section of the webcast today, and we'll be looking specifically in this one at Lambeth and some of the information we've got from your local area that is telling you some of the areas that you may have and some of the issues that you need to look at to address, and then how we can potentially use some best practice measures that I picked up around that can help deliver on that really. Again, any questions you've got, if I'm not delivering on some of the things that you thought that this session will deliver, then please give me these questions for the next sessions. And just to answer a quick question, Catherine has asked, what is an alliance contract? Well, alliance contract quite often is a contract or an agreement between a group of providers that they will work to some fundamental terms and conditions in a joined up way. So quite often it's sort of bringing together 4 or 5 potential providers or even commissioners together to say that we are all working together to achieve this. We're all going to deliver, to provide this. We're all going to work in this sort of way. We're going to work in this sort of decision-making process. So it sets out the direction of how it's working together. You hopefully will work towards that output, because quite often when people get in a room, they've all got their own agendas. They all want to do something different. They all have a different measure of what success and what the output is. And that's when conversations break down very, very quickly. So an alliance agreement is, let's set out the clear approach working together in which we will hopefully achieve the outcome and ability of what our commissioning intentions are doing. So I hope that's helpful. As I said, we'll come back at 15:10. Any questions, please put them in the chat box and we'll pick them up at the beginning of the last session. Thank you. Okay, welcome back everybody. Just looking at that poll there I put up about how do you think you can best support delivering the CCG Commission strategy, and there's 4 questions you can tick, one or all 4. The most popular obviously participate in the programmes of work, and the least popular being setting the agenda. Personally, I think all 4, because as clinical leaders, as commissioners, as people who contribute to the whole commissioning strategy, you all have a part in setting the agenda. And also as a part about owning the agenda as well. I think it's probably not ideal for anyone who's, or any team working together, to be able to deliver services changes or whatever you're trying to do without feeling some sort of ownership around that, really. So probably may not feel at times that you do have that ownership, but absolutely working with your other colleagues and how your structures work within your CCG, really promoting that your voice and your expertise and knowledge, to not only just set the agenda, but as the other comments about delivering the work, participating in the work programmes, and keeping out on that communication out to colleagues, and for those who have direct contact with patients, the patients themselves, and keep them sort of engaged as what's going on, why it's going on, and take an interest in their views and what they feel about that, really. I think, like a lot of agendas, sort of not everyone's always 100%, but I guess if everyone's signed up to the commission strategy, then it's important that people are all part of those agendas as well, really. Just looking at some of the comments that people have left, especially around who is Joe Public. Well, I guess who is Joe Public, I suppose, is those, it covers a wide range of different individuals, really, and I guess those ones that use our services the most or impact on us are the ones that we have to strongly focus on working with, really. Okay, so just going to go through the last part of the webcast today. So we'll look at some detailed information we've got from the Right Care in Lambeth, and some of the information that's come out of that, really. So I've just broadcast those results of the poll there, and you can see where people have ticked on those comments, hopefully. Okay. So what actually is happening in Lambeth, especially those people who are working on the front line, I think you'll be very familiar as to what is happening in Lambeth, and also other colleagues that are working with other colleagues across the system will be aware of the challenges and the issues that are being faced by the public in Lambeth, really, and therefore the priorities and the challenges that you have as a clinical commissioning group. There's a document that was produced earlier this year called Right Care Right Now, and really it was for all CCGs. From NHS England perspective, they sourced information and data across all the CCGs, which would inform them around what are the key challenges and areas. Some of them, I'm sure, are disputable, and sometimes the data is not always as strong as it could be, or people may not think it's as strong as what it is. But I think it certainly does give an indication and a flavour as to what are the challenges facing Lambeth, really. And this document, which you can easily obtain probably from colleagues within the CCG, but you can actually just get it on the internet anyway. If you just put in Right Care for Lambeth CCG on a Google search, it'll come up and you'll get that document that's PDF'd. And it looks at a number of things, really. It looks like operational productivity, your allocation efficiency and demand, and also then links into sort of some conclusions that have been met, and then might indicate to you then about new care models or a new approach or a new way about setting those priorities that you may want to review services and commission differently. What's in the document really is what I've got on these slides is just a few slides from sort of a larger document, and it can be quite an interesting read, actually, and it'll be interesting, especially for clinical colleagues, to see whether you feel as if those areas of stand out or something that you come across within your normal daily work, really. So the idea of this document is where to look and what information has been sourced. And again, it's been sourced directly from national data that's been fed in from your local CCGs and providers. What are the areas that you need to change, and then ideally how are you going to change them, really? So what they've also done is they've clustered your CCG in with other CCGs of similar demographics, similar population type. So in theory, you should have very similar needs and very similar outputs of of good, bad, and indifferent health presentations, really. And then it looks at some of the range of opportunities, and then helps you support them, and gives you a focus really on what to change now. So where can lives be saved? When you look at the information that came out around Lambeth, and when they looked at sort of these rates, the areas that stood out more than your comparative 10 areas were areas that needed to that where potential lives could be changed. They specifically looked at respiratory, GI, and neurological. So they seem to be areas where other similar CCGs tend to have a better life expectancy than Lambeth do around those clinical areas. In terms of where savings can be made, in other words, when we looked at, or when the document and the data behind it looked at the spend that you spend in your area on different disease groups compared to where others spend, but actually have similar outcomes, it appeared that you spend a lot more on cancer than your 10 CCGs that you've been benchmarked against with similar populations, similar demographics, certainly around circulation, respiratory, neurological, trauma, and GU as well were other areas. So these are the areas that you, for some reason, you spend more money per population on those disease groups than a neighbouring CCG that has a similar demographic. So I guess the question is, why are you spending more than someone else around those sort of areas, really? And potentially, if they're getting similar quality outputs but spending less, what are they doing differently that maybe you could adopt in your CCG area? And when they looked at the similar about where you're spending more money admissions, and again, cancer, GI, trauma, GU, and musculoskeletal were other areas that you stood out more. So you seem to be spending more money on cancer, non-elective, GI, and trauma. So again, if other neighbouring CCGs with similar demographics are actually spending less and managing their patients better in the community, what are the things that they are doing that is enabling them to keep those patients in the community rather than them becoming non-elective admissions? So again, have they got different pathways around these conditions? Have they got different services in the community around those conditions? What is it they're doing differently? And also in the document, it looks like pathways on a page modelling. So they sort of look at a condition and how it affects the young, sort of middle-aged and older groups, and where do you tend to be an outlier around quality outcomes or spend on those areas, and where are you better in those areas? And as I said, I've only got a couple of slides here from a couple of condition pathways, but there are a lot more in there, really. So one of the ones that jumped out really was around lung cancer pathway. So again, be interested if there's any comments that anybody has, so please put them in the chat box. But when you look at these areas, it looks at sort of how you compare around different elements that would impact on lung cancer potentially, whether in early stages, in treatment, or in long-term conditions. So, you know, is your area suffers more deprivation, and does it have more lung cancer prevalence? What are your smoking rates? How do your patients quit smoking? Your public quit smoking better? How many urgent GP referrals have come through to the system based on potential lung cancer? Your elective spend or non-elective spend, and your detection rates. So again, in terms of the areas that you are better at compared to your 10 comparative CCG areas, you are better at detecting at the early stage. You have better mortality rates than they do. So you obviously have people with lung cancer and you're detecting them better, but those with lung cancer are, for some reason, creating a higher than average or benchmarked amount of non-elective spend. So you're detecting them, but when they are ill, they tend to create more non-elective admissions. In terms of elective spend, you tend to have a lower rate, so you tend to do less elective admissions for lung cancer. or better rate, but it's your non-elective that's a problem. And also your quitters are not as good in comparative to your local CCGs as well, really. Again, this is just data that's come out. Again, data is always open to interpretation, but these are data sources that all areas submit and share. And this is sort of how these figures have come out to measure, really. So you seem to be detecting people earlier, but of course you are having more because you have less successful quitters, and a lot of those patients seem to have a lot of non-elective spend spent on them. So how are we managing these patients in the community? Potentially that would reduce non-elective admissions. Again, that's just what jumps out at me, but whether it's absolutely correct or not is for those of you who will be closer to that in your area, you'll have a more better idea around that. In terms of asthma, again, across this sort of pathway from sort of prevalence to conditions and management, again, there's quite a variance in Lambeth compared to your 10 sort of areas of similarity. So you have a slightly higher prevalence. You have your primary care prescribing is less. Your non-elective spend is less on asthma, but your emergency admissions rate for children with asthma is a lot higher than your comparative areas, but your mortality from asthma is better as well. So again, the thing that jumps out at me there is it's the emergency admissions for children with asthma. And again, why is that? Why are those non-electives creating that sort of demand in your local hospital, which is costing you as a CCG a lot more money than ideally you'd like to spend on emergency admissions? So why is it that the public are going through a non-elective emergency admission for children with asthma? And I know in areas I've worked before, there's been a concerted effort that, similar presentation where there's a lot of children attending the A&E or the children's A&E with asthma. And what they discovered was that how those young children use inhalers wasn't very good. They used them wrong. And I think some of the evidence suggests that 80% of people who have inhalers don't use them properly. And they went on because a lot of these patients that came in for a short non-elective admission, 12-hour stay, went home. So it was just about alleviating those initial acute symptoms. And what they discovered was actually the usage and how they use inhalers for children was really, really poor. So they went on a sort of educational campaign to teach parents and children how to use inhalers better. So when they do become short of breath, they were using them correctly, getting the best benefit out of them. And what was discovered from that was certainly a much reduced non-elective emergency admissions into the A&E department. What I also found in this right care document was that 2% of Lambeth patients are spending 16% of the budget. And they looked at this information through this sort of data that came through. So 2% of your most complex patients, which is creating 16% of your spend, which in turn is equivalent to £18.5 million. So when they looked at the age of 0, they found that 30 patients, babies obviously, were having on average 3.5 admissions over a year. They on average had 2 conditions that they're predominantly presenting with, and it was costing close to £1.2 million a year. Again, when you look at the sort of older group from 60 years above, that is 60, 70, 80 patients that fall into those age brackets, that some of them are having up to 8 admissions a year. They had predominantly had 3 specific conditions that was causing those admissions, and for that one was costing £1.6 million a year. So again, the question I suppose to be asked is, who are these people? Well, we must know who these people are because we've got their records from their attendances and their admission rates. And I guess you could look at, well, which practices are they attached to? Is there something that those practices or the community services that support that practice or those particular patients, what are they doing about managing those patients? What is the cause of those admissions? That for some groups in this 20 to 29, on average sort of 11 to 13 admissions a year. And I guess we probably know that these are very challenging patients. There may be patients who've got alcohol dependency and other areas like that. But there are 800 patients in the Lambeth area out of a population of hundreds of thousands that are spending 16% of your budget, which is equated to £18.5 million. So who are these patients? Why are they creating all these admissions? What pathways are they on or not on? How are we managing them? What is the input they're having in the community? And therefore, with some of them, I accept not all of them, but with some of them, what can we do differently? What can we commission differently? What can we do about changing the pathways or services, etc., that may cost us an extra £6 million to implement, but actually may save £10 million off that budget because of those admissions. So again, understanding around that and how that works. So in summary, from this data, and I said there's a much bigger document, you'll have more information in there that probably is quite an interesting read that will give you some sort of specific priorities around the population in your area, that it's coming out with sort of these summary figures really around spend, attendances, admissions, etc., etc. So you could argue they are the patients. When we talked earlier about commissioners setting priorities and looking at who are the ones I need to focus on, which will give us the greatest benefit to their quality and their health outcome, as well as to the financial benefit of the CCG. These are the patients that need to be managed better. In terms of the right care plans for Lambeth, Brian, who you'll probably know, Brian Reynolds, is leading on a lot of strategy and performance, but some of the actions that are currently being taken is that the CCG is looking at all this data through the national and local means, and it is supporting the planning and commissioning. It will be part of the programme and boards for the right care models, which will go through over the next 2 years. An update report is actually going to imminently to the board meeting this month to sort of describe about the approaches and how that data is going to inform and create the work programme for the CCG over the next couple of years. There will be a right care link person that you'll be able to link into. So in the areas of where you're focusing on the CCG in terms of where there's planned, unplanned cancer, or those areas, there will be someone who you'll be able to link in with, who will be able to provide more information and more detail to support you in the work that you're doing. And it's certainly, the approach is, is advised to take a strong clinical-led way and focus on 2 or 3 areas of opportunity to maximise the patient from the treatment and the value of the whole population. So focusing on these really key individuals and key groups will create big wins potentially for the CCG and for the health benefits of not only those patients but potentially other patients that may have fallen into that sort of category but may not do now with redesign of commissioning pathways and approaches. Where else can you look for locally through the direction of travel? Well, you've got all the strategies, all the public feedback, and I think we touched on some of those areas earlier on in terms of where you can get information from to support the work you're trying to do. So based on this data, what are your approaches going to be? What are the things that you're going to look at in your commissioning process in the short, medium and long term? Well, again, here's quite a big list. If you can tick all them boxes, then you'll be absolutely firing and on all cylinders to be able to deliver that. But these are sort of the things that need to be looked at, to be taken into account in your day-to-day work, from your clinical perspective, from your commissioning perspective, whether it's through finance, data sharing and information, and how are these, so trying to look at these particular key areas, then you will hopefully be certainly on the right track in line with the commission cycle and the national objectives to be able to deliver better health for your public. What have others achieved based on their profile? And as I said earlier, there are several websites and lots of information out there where people actually have put in new changes to service pathways, service redesign, recommission services in a different way to be able to give real benefit. And I've just picked out 5 which may link into some of the areas that you have. So in Bradford, they looked at type 2 diabetes detection, and because of that, they have been able to detect a greater range of people and therefore put services in place so that they don't hopefully will maintain the diabetes or certainly reduce the complications that come with that. In Ashford CCG, they've had a 36% reduction in GP referrals to MSK by running a locally triaged service. And I know from the webcast we did last week, some of your colleagues were saying that some of these services you have got in place, which is great. Maybe need to question how effective they are. Can they do something different? Can we do more with these services? But certainly in Ashford, they have a much better reduction of referrals into secondary care by using the locally run triage service. In Slough, they had significant reductions in unplanned activity with patients with complex care via proactive primary care. So what were they doing differently in primary care? Not necessarily doing more of something or creating more workload, but actually about doing something differently around that. In Hardwick CCG, they had a reduction of 30% of COPD emergency activity because they redesigned the whole pathway, the whole way patients entered the system, how they were dressed through the system, where they may have had other interventions along that pathway in the system, which stopped short of people actually then having that emergency activity through a non-elective approach, and then ending up in your local hospitals, and as you know, probably ending them there for days, if not weeks, which is something that could have been avoided. And in Blackpool, they created a 98% reduction in calls for frequent callers via enhanced integrated care and pathway navigation. And Blackpool area is renowned as one of the worst areas for drug and alcohol problems and homelessness issues, and have a huge challenges around that area, and probably have what we call frequent flyers, high health users to services, especially probably in the A&E departments and ambulance services. But by providing this enhanced integrated care pathway and navigation process, they had a dramatic reduction in calls and that sort of benefit around that area. If there's anything else that people are doing at the moment that other colleagues on the webcast might not be aware of, then certainly put them in the chat box and share them around really. But these are just some of the examples that people can take forward and use. And again, if you've got ideas and thoughts with your colleagues in your teams about how you can take these processes forward and actually look at a process for change, I would certainly ask you to look at these questions about, are you clear about the CCG plans? Is what you're thinking about aligned to these plans? Is it aligned to the commission cycle, or what stage in the commission cycle is it? Is this something you need to invest to save or save to invest? Who needs to be involved? Where does sign-off need to happen? Do you have that clinical buy-in and that clinical evidence to support that? And what sort of formal reports will you be required to do? And then it is about putting together an outline case for change. So if you recognise you may have an issue around asthma management and you've got the data to support it, you've looked at the best practice, and it's led you to potentially re-specify a service that's in the community, redesign a pathway in the community, move a level of resource from one provider potentially to another because they can provide those interventions that will help and develop better those outcomes that you're trying to do. Then in your case for change, these are the things that you'll need to include. And I guess most CCGs don't want a document that is 10 or 15 pages long, but just a short document that is clear, concise, easy to read and easy to follow, but actually will address these areas that are bullet points in this slide. Because if you don't address these areas, the chances are it will come back with a question as in, how will it do the things that they're asking? So are you clear about the challenge, the dilemma, and the solution that you're looking to put forward? Is it transactional or transformational? Does it have the data and information to support it so people can see exactly why you come to those conclusions around that? Does it fit in with your current landscape and your strategy? Does it fit in with the solution? Are there any blocks to that? Will you need to look at potentially a different contractual or procurement process? What is the timeline for delivery? And what will be these outputs? What will be the change that takes place? And what will be the success factors that you think this case for change will deliver? And again, if that's really, really strong and really, really detailed at the beginning, it will help tremendously the process that you'll need to go forward to actually put that process in place. I know some of this slide next one might be slightly updated since these were put in, but obviously there'll be different sort of program boards and groups in which you will be able to escalate, albeit members of attending really. And Lucy's just put a comment that in terms of recommission intentions, still need to agree detail on finance and activity, and even when the intentions agreed, it'd be good to inform service specifications. Absolutely, Lucy, completely agree with that. Have to nail down at the beginning the clear vision. What is changing? How are you going to measure? How are you going to commission and specify what's going to happen? That will be the only way really that hopefully, and if the evidence is supportive and the best practice is a good example, that you'll be able to deliver that. So you'll have your process locally around program boards. You'll have other committees as well that potentially your business case or your discussion will need to go through to get sorted. And again, I'm sure the CCG is trying to make it as less bureaucratic as possible, but certainly it will need that sort of strong governance process around that to ensure that that's being managed and detailed. One thing for our GP colleagues really and other clinical colleagues that may have interests or work in other areas that may create a conflict of interest, I think it's important that you are very clear about those conflicts of interest and the process that goes with it. NHS England has just produced in the last few months some draft guidance about managing conflict of interest, but most CCGs, and I guess Lambeth will be no different, will have within their policies and procedures reference to conflict of interest. But the 5 key areas are normally about being very transparent, declaring your conflict of interest in meetings or decision-making processes, checking obviously that links in with the CCG code of conduct, excluding yourself potentially if you're going to be a potential provider or bidder for something from that process, and also one other thing that this document picks up is that for GP colleagues in particular, when you're referring patients and advising patients about areas where they may need to go for treatment, then you may have to declare that conflict of interest as well, just so they're aware of that. But I think Lucy's then that it's set out in your constitutional and governance arrangement framework. In terms of the current challenges with the CCG and talking to your colleagues, yes, I think your CCG has the same challenges as most places. It is about workforce, it is about resources, it is the challenge of meeting those outcomes in the 5-year forward view. And this year, as I sort of said at the beginning of the webcast, that it is about your CCG being measured now against the NHS Improvement and Assessment Framework, which is very much around outcome-based evidence of commissioning services. So I think it looks at things like maternity, it looks at cancer, I think it looks at cardiology as well, and another couple of areas. But I think people accept that this is a huge challenge. People do accept that it's going to be really difficult to drive this forward. So trying to look at everything at once, it is about, for me, approaching it in a number of key ways. One is aim for your biggest wins, focused on where the biggest benefits will be to your health, the health of your local population and your health economy, keeping it simple, being clear and concise about where you want to go and what you're trying to achieve, keeping to those commissioning principles, following the cycle, because as I said earlier on, if you don't follow the elements of the cycle, there's a strong risk that the approach you're going to try and take will fail. I think we have to accept nothing is protected now. Everything is up for scrutiny. Even some of the things that people would find, you can't really touch that service or can't really evaluate that treatment or intervention. Nothing is protected anymore. Everything needs to be looked at. Wherever the focus is and the direction, it must be on tangible outcomes. And it needs to, is it creating value? And that is not just about money, is it creating value about clinical outcome and clinical indicators? Using the processes available. So again, go back to the NHS contract to manage current providers better and more effectively in a more lean manner. Procurement may be one of the options that you need to look at. And we've got those rules and regulations we need to work to. If something isn't working, if it's not providing with any information, that the results and the outputs are not really tangible, then why don't you just stop it? yes, you may have to do a sort of an impact assessment around those areas, but if it's not clearly showing the benefit that you expecting it to deliver, then it needs to be stopped, or the service needs to be reviewed with some clear new outcomes or clear measures of what it is ideally supposed to be done, and then it needs to be put into that agreement, whether it's a service level agreement or a contract with them. And these can be services that may be only a value of 50 or £100,000, but they need, and then you can look at 6 months later to see whether your suspicions that it was doing well or not have been proved. But putting money into services that there's no real management, there's no real focus, there's no real evidence, then you have to ask the question, why are we investing in that service? And then the other areas, you don't have to do all of this on your own either, because your challenges will be the same for your neighbouring CCGs as well. So if somebody's looking at a pathway around cardiology or something else, then why not join in and work across CCG around creating something together, spread the workload. Not everybody has to do everything. You can work across that. If another CCG has just purchased a service in their area, that looks really, really good, it's demonstrating really good outcomes, they've gone through that sort of process, why not commission it yourself, become an associate to that contract, open that service up as a choice option to your local population as well. It doesn't mean that everyone has to do everything themselves and we can't work collaboratively across areas. And by taking some of those approaches and working through them and holding to them, then that hopefully will help you with the limited workforce you've got and will help you achieve those outcomes that you're trying to achieve. We're just moving towards the end of the webcast now. So some of the other key issues you need to take into account as I mentioned earlier, is about being brave, standing up, being accountable for what you're trying to do and holding others to be accountable for what those services they're providing as well. Keeping aligned, whatever you're doing, keep it aligned to those NHS principles. You will get other organisations or individuals who may want to block that trajectory because they may have vested interests. It may be because they means they will have to work in a different way, which is not the way they want to work into. But if those ways of working, if those interests are not aligned to the NHS principles, then that gives you your clear license for me to go in and say, we're stopping it, we're changing it, we're doing something different. When the argument comes back, oh yeah, because we think it should stay because of this, that and the other. If the view is it's not aligned to those NHS principles, as far as I'm concerned, it's not what we should be doing, it's not what our NHS constitution says, it's not what the NHS is trying to deliver, that gives me license to make that change and stop that change. It is about also winning hearts of mind of other individuals as well, so you've got a buy-in and on board around that. And it is ideas that need to be aligned to provider drivers, motivations and culture, because quite often, sometimes they're not always aligned to the strategic direction that you want to go to. So it's about picking your way through that. Keep to the commission cycle, keep talking to providers. Whilst on one hand I'm saying we need to give them a bit more of a challenge and time and stand up to them more, but we still need to keep that engagement with them. And through engagement you may be able to create change or a different approach. But if they're just not interested because of their own drivers, motivations or culture, then that gives you clear license to be able to do something differently. And of course, moving into responsiveness to working in partnership with other CCGs and collaboration. There's lots out there to guide you. There's lots of examples of best practice, and I just picked out a number of websites where there's lots of information that you can use and work on. Once you've, as I said, understood what your priorities, look at all those examples that can work through that as well. Okay, and that's the end of certainly the presentation to me for the webcast today. I hope that has met the outcomes that we sort of set ourselves at the beginning of it around that. Is there anybody that has any final questions they'd like to ask? Anything they want to challenge me back on? Is there anything that they want to share with their colleagues who are online at the moment? Then please put those questions in the chat box now and we can try and respond to those as well. One thing I've also been asked is, obviously this is a webcast that's been supported by the CCG to try and support yourselves and terms of the work you're doing, really. So they're quite keen to understand whether this did, and the content of the discussion and the slides did actually meet some of the needs and areas that you were looking to for them to be addressed. And if there are, great. If there isn't, then please fill out the feedback form. And also be interested to know whether you felt doing something like this on a webcast approach is beneficial and easier than being in a classroom for a day or half a day or whatever, really. So Rimmel is now demystified, so good for that. I hope you are, and I hope that has been helpful in what you were looking for, really. So as I said, yeah, please fill out the feedback report. Just looking at some of the comments. Lucy just thanked everybody. It's a new way of training, hopes to reduce travel time, and we'll have a recording of this for new starters. So very keen to get some sort of feedback. Sarah's put very helpful, though it seems unbelievably complex and like juggling lots of balls. I'll be honest, I've worked in commissioning for a number of years, and actually, if you just stick to some key principles, and I appreciate the process we have to follow can be quite challenging, but keeping to some of the key principles, then you shouldn't go far wrong, and it should be easier. Sometimes it may take a bit of work at the beginning, but then managing and ensuring those services are delivering what you want it to do is a hell of a lot easier through performance management if you get it right at the beginning. And Lucy just reinforces that whilst it is and it can be complex, there's lots of support within the CCG to help colleagues to get on with that journey and try and make those changes and alleviate those frustrations, especially with our clinical colleagues, to try and make things different and move them forward for the public. I'll come off the webcam now, but I'll keep the speaker open in terms of any more feedback I can give on the comments there. But thanks again for your time, and I know it's very valuable. Well, Sylvia, Lucy's told you there's lots of support, so you'll know where to go to now. Thanks, David, for your comments. I'm not sure if there's anyone else typing anything now, but if you want to log out of the webcast now, then please feel free to do so.